I'm going to present you, I would say, a surgical case. Please, if you can present it was initially sent for video session, but it was accepted by the organizers for the oral presentation, and I thank them for that. It's a long title, meaning that it was also a long and complex surgery, and you will see why. So this is a 40 years old male patient with high myopia and some astigmatism. He received artisan refractive lens several years ago, 20 years ago almost, and he didn't show up to us anymore because he was very happy until 2019 when he came with decreased vision in OD. And indeed we found the slit lamp exam, bullous keratopathy with no achievable endothelial cell count measurement, but good position of the artisan lens and mild iridophysocdonesis in this eye. The left eye, shown down there, had no pathological findings and an ECC of 1300. We made a decision to perform a combined procedure in posterior lamellar keratoplasty associated with artisan lens removal and clear lens extraction with PCIOL. But we had some preoperative challenges. Of course, in cases like this, the biometry, it's more difficult to be done. It was impossible to be done with optic biometry. At that time we had only IOL Master 500 and Aladdin, so we did ultrasound biometry, including the B biometry. The axial length of 22.5 is not that high, would not explain such a high myopia. The K readings, about 46, could explain the high myopia. Anyway, we had seen on all the biometer machines a thick lens, and also this iridophysocdonesis with no history of trauma put us some questions. We thought about a microspherophakia, we performed UBM. The data were not that concludent because of the reflexes done by the artisan lens. But you can see here in yellow a thick lens of more than 5.3 millimeters. So this is the surgery. Of course, we dilated the pupil because our intention was to deal with the lens as well. And to our surprise, we had this iris getting out of the anterior chamber only after injecting OVD. And this is OVD, but sooner we saw a large you can see here the zonula is extending, and here it's already a broken area of the zonular area, and we perform, of course, local vitrectomy. We sutured all the incision. Remember, these eyes have thin sclera, and this patient already had a surgery in this area when we implanted the iris globe 20 years before. And look, during the CCC, we had this surprise. Indeed, the zonula is very lax, has shown laxity, is very elongated, difficult to perform the capsulorhexis. We used some hooks on the CCC, continued with the phaco and cortex aspiration. Eventually, we had very well cleaned the lens, the natural transparent lens, but we decided to remove completely the bag and to put an aqueous IOL sutured at sclera in 4 points with Gore-Tex. As a matter of fact, nowadays this is my preferred technique in such cases when I don't have at all capsular support. And everything went well. Of course, we needed to suture the sclera and perform the inferior iridectomy, and now we go on with the second step of the surgery, the ultra-thin dissect itself. I always use only air in the anterior chamber, never use OVD when I have lamellar procedure, because I need to have a better stability of the graft attached to the stroma. And the lamella was prepared in the OR using microkeratome, and we used the Busin glide, so the UT dissect went more or less as a standard procedure. Several sutures, it's better to have several sutures to be sure that everything is well closed and you can remove them afterwards. The third day post-op, the eye looked very nice, the attached lamella on the OCT as well, we had a nice image. 10 days post-op, again we have a nice image. We could do an UBM which showed a very nice stable IOL sutured at sclera, and to our happiness, the patient just came 1 month ago. Of course, he comes to us now every 6 months, but he came with 20/20 visual acuity, or less amount of astigmatism, clear cornea, nice graft, good IOP. The ACC is not that high, but it's stable in the last 2.5 years. So we are, let's say, optimistic about his eye. As a conclusion, after, as we all know, after several years of post-artisan or artiflex refractive lens implantation, a percent which is variable, but most of the, and in our experience we have about 1% implanted patients develop endothelial decompensation. The anterior chamber refractive lens, as the most probable cause of the corneal damage, must be removed. But the patients want to remain emmetropic because they were emmetropic in the last 20 years and they were very happy with that. So they don't like to come again to the minus 15 or 11 or whatever. So we need to perform also in the same time phakic lens removal, refractive lens exchange, and posterior chamber implantation according to the new biometry. This can be done either in sequential procedure or in combined. We prefer the combined ones because the patients also prefer all in one. And when you deal with zonular disease, you need to adapt the surgical plan like we did in our case. You can choose whatever of the methods or the techniques you are used to and you prefer. As I just showed, we prefer the aqueous lens sutured with Gore-Tex. But in terms of endothelial keratoplasty, UTD-SEC evolves like a standard procedure. DMEC is an option as well, despite this complicated eye, but we all know the higher rate of rebubble needing in DMEC eyes, especially in eyes with deep anterior chamber like this one, in eyes with communication between the anterior and posterior segment, and that's why we prefer to have UTD-SEC. And when you deal with myopic eyes, always check the nature and cause of the myopia, and don't forget to remember the possibility of microspherophakia like we had in this eye. But when you have an excellent graft supplier and a good surgical technique, the results can be very good despite possible and unpleasant surprises. On this occasion, I want to thank to the Veneto Bank in Venice, with which we have a very good collaboration. Thank you. This is a presentation with several cases. As we know, malposition of an intraocular lens, either it is anterior chamber or pupillar or even posterior chamber IOL, is one of the major causes of corneal decompensation needing corneal transplant. Together with the keratoplasty, either penetrating or endothelial, it is advisable to remove the guilty IOL and to replace it with a correct position posterior IOL, far from the cornea and from the graft. And you can do this either in concrete procedure or sequential surgeries. We selected 14 patients with bullous keratopathy determined by different types of IOLs, Fyodorov pupillary IOL, anterior chamber IOL, and the third group is with dislocated posterior chamber IOL, to whom we perform concurrent procedures, ultra-thin DSEC with IOL removal and the new IOL implantation according to the local anatomy. In our series, all of them had combined procedure. Regarding the IOL, there were 3 situations. First group, anterior chamber or pupillary IOL have been removed and we put a posterior PC IOL on capsular remnants. The second group, either AC IOL or pupillary IOL were removed, but we had no capsular support at all. We removed them and we need to put another one fixed on sclera, sutured. And the third group is a posterior chamber IOL dislocated with a capsular bag, and we needed to reposition this pre-existing PC IOL. So we kept the bag and the IOL in reposition. Here are some examples. All of them have PC IOL on capsular remnants, so not sutured. In this case, we have a Fyodorov lens and pre-op. The superior line shows the pre-op images and the bottom line, the post-op images. Again, some cases when we needed to suture a sclera, the PC IOL, because there was no capsular support. Here we have Fyodorov lenses, and this is a post-op images. In some cases we needed also pupilloplasty, you will see the video. And here we had also IOL sutured at sclera, but this time we had anterior chamber IOLs. This is a case who required afterwards a second transplant, which was a PK. And the third group, these are 3 cases of old patients over 80 years old with dislocated IOL, posterior chamber IOL. You can see here the limit of the bag and the IOL and how they looked post-operatively in these combined procedures. So this is the first one of the cases. I will go quite briefly through them. This is a Fyodorov lens which needed to be explanted. In these cases, as you will see again, ultra-thin DSEC part of the surgery is more or less standard. But one of the most difficult parts of the surgery is to deal with the IOL, the guilty IOL, which needed to be explanted. And Fyodorov, maybe the younger doctors don't know, they have 3 haptics anterior to the iris and 3 round haptics, closed haptics posterior to the iris. So we need to cut the anterior ones and then to cut the posterior ones. extract the optic part, and then go and chasing the round haptics remain behind the iris. Of course, anterior vitrectomy, and again my favorite technique at that time, that was 4 or 5 years ago, we didn't have Goretex, so we used acrylic suture with Prolen in ab interno technique. Here you can see the dissect, again lamella prepared in the OR using Busin glide, and the final image quite nice. And this is a similar case. I just wanted to show you that in this case there were plenty of remaining cortex, and we ask ourselves, should we need to remove them or just leave it there? But if you leave it there, you can have a tilt IOL afterwards, so it's preferable to clean everything together with the vitreous, of course. But in this case, in some cases, when you remove the pupillary IOL and the cortex remnants, you can have ruptures of the structure of the sphincter, so you need to perform pupilloplasty, like in this case. And this is the third one. I will go even further. Again, you have a Fyodorov IOL, again the same difficulty in explanting it. With you have to be careful not to leave it, you don't want to have them on the retina, but because we carefully examined the periphery and we saw that there are significant and sufficient capsular remnants, we implanted the 3 pieces Alcon IOL on the capsular remnants, and this is what we did. The same thing here, only that here we have an anterior chamber IOL, which is much easier to be explanted if it's not buried in the iris or whatever more complicated eyes, like traumatized eyes can be. And again, we have sufficient peripheral capsular remnants, but be careful, you need to have sufficient capsular remnants, otherwise you can have a dislocated IOL and you can find it on the retina or something. This eyes went quite well. This is the post-op image. And this is the third group of the case that I mentioned, all patients with pseudoexfoliative syndrome and posterior chamber IOL dislocated together with a bag. We used the anterior approach. We prepared scleral grooves because our intention is to keep this IOL, and we always keep the IOL when we have favorable IOLs. I mean IOLs which have holes on the haptics. It's a pity not to use them, and it's a less traumatic procedure instead of taking it out and exchanging with another IOL. We are using hooks to fixate the bag on the CCC. First, as you saw, we externalized the superior haptic and then the opposite haptic, and we sutured it with Prolen suture. Then we passed to the second part of the surgery, dissect, and again this is more or less the same standard technique for dissect. All surgeries were uneventful. All eyes had well-positioned PCIOL after the combined procedure. All cases had significant improvement in visual acuity, which was present throughout the follow-up time for 5 years, and had no significant complication except for some cases. One eye needed early rebubble, but it went okay afterwards. One case developed early host cornea trophic ulceration, which was solved only with penetrating keratoplasty, and she did well afterwards. And one case developed secondary glaucoma who needed filtering surgery, but the same case had late endothelial failure at 4 years, and he just had recent dissect. These complex eyes need personalized approach according to the local situation, and the decision for which type of keratoplasty and which type of IOL are the most appropriate for each patient belongs to the surgeon and his experience. When the decision is for endothelial transplant, the challenges are mostly related to the management of the IOL, the port visualization, IOL removal itself, completed cleaning of the anterior chamber, incision placements, and so on. All of them can be challenging, but the UT dissect part of the surgery is more or less standard, apart from the communication between the anterior and the posterior cavity, which can lead to air bubble escape. Thank you very much.